Hello. Hello. Am I audible? Hello. Okay. So as the day progresses, we will start. No. We will start our fourth RIRS case.
Hello.
42-year male patient.
Hello, RIRS OT. Just stay there for a while. 2 minutes. Give us 2 minutes.
Okay.
We are with Dr. Narayan.
Okay, sir.
RIRS, give us a little bit of quick resume in the case. Hello, RIRS OT.
Huh?
Hello,
Hello, sir. Hello.
RIRS OT.
Yes, sir.
We are telling about the case which you will be doing.
Hello.
Yeah, we are listening. We are hearing you.
Okay, sir. Now we will start our fourth RIRS case. A 42-year male patient, known case of bronchial asthma, had came with complaint of left flank pain for the last 1.5 months. Now the patient had one episode of hematuria 1 month back. Patient also had in 2005 a right URSLC. Now at present on examination the vitals are stable, for abdomen soft, no tenderness on bilateral flank, hemoglobin 16.2, creatinine 0.95, TLC 6700, urine RE partial 1 to 2 per high power field, and urine CS there is no growth. NCCT KUB report suggested left-sided nephrolithiasis 1.26 centimeter in the left inferior calyx. Also there is urinary bladder, multiple calculi near the right VUJ. This is the CT scan plate and the report is there.
So there is no hydronephros on the right side, although there are collection of stone in the region of the right VUJ. And the stone in the left side is in the lower polar of the kidney.
Yes, sir. So over to OT now.
Are you ready with the OT or we go to the HOLEP OT and come back?
Hello. I think we need 2 to 5 minutes.
Okay, fine. We are putting you to mute and let us know once you are ready.
Okay, sir.
I've given an incision on the left.
Hello, anybody in that auditorium? Hello, anybody in auditorium? নুনালো দেখো তো কেউ আছে কিনা ওখানে যে মাইক্রোফোনটা নিতে পারে একটু ওটি ওটার RIRS এর মাইক্রোফোন RIRS এর OT1 না আছে সবাই অজিত anybody in the auditorium? Hello? নির্মাল্য মাইক্রোফোনটা কাউকে নিতে বলো একবার শুনতে পাচ্ছি কিনা একবার দেখি দেখ তো মাইক্রোফোনটা ওখানে কেউ আছে কিনা? না, মাইক্রোফোনটা চেয়ারের উপর পড়ে আছে, যেখান থেকে আমি চার্জ। না, দুটো মাইক্রোফোন আছে, একটা অন করতে হবে, কোনটা অন করবে কে জানে। রাজেশকে দাও, রাজেশকে দুটো। হ্যালো, এখান থেকে শোনা যাবে? I cannot hear you from the auditorium. Rajesh, Dr. Lunia. Dr. Lunia, can you hear me?
Hello.
Yeah, I can faintly hear. Is Dr. Lunia there, Rajesh Lunia?
Yes, sir, I'm here. Hello, can you hear me, sir? Hello. Hello.
Rajesh, can you hear me?
I can hear you, sir.
Oh, I can hear you now, faintly. A little bit louder would have helped me.
Sir,
Okay, that doesn't matter. I'm just, we are in between the cases, so there will be an HOLEP and the RIRS coming up. So there is a gap, interval, and if we have had the lunch, might as well relax. I take the opportunity of just overviewing the RIRS equipments and a little bit of tips and tricks. There's nothing great about it. We have all watched Dr. Maharaj performing wonderfully on the RIRS. And I think we don't have to talk much about this RIRS, and it is just to emphasize on Michael Grassu's landmark paper in 2000 that initiated the RIRS process in a big way, and that time his success rate was 81%. I think now with the equipments it has come much better success rate. So we all know about these guidelines of EAU and AU. I'm not going into that one. Those are the PNL, IRS, SWL for the more than 2 centimeter, less than 1 centimeter. RIRS and SWL gets a priority. 10 to 20 is the gray area. We can have SWL or endourology. The lower polar stone is a problem, which is not favorable for the SWL. So either RIRS or PNL, the PCNL is more favored. And that's all the lower polar study group says. And as you see over the whole world, the RIRS is coming, taking the driving seat, putting SWL and even PCNL in the back seat, and more advanced equipments are possible, keeping the stone-free rate to the higher degree. Now, the RIRS, the key to the success is the technical improvement. We started with the 9.5 French, and then came to the 7.5 French, now to the 6.5 French. And also, by digitalization, the integrated light source had made the vision much more slicker, and the longevity of the scope is also increased. Now, what is important is the access sheet. Like the instrument itself, the access sheet is equally important. As you can see, if you go back to the previous one, we have got the sheet which has got the different varieties of make. They have made the Olympus, the Wolf, Stores, ACMI, and now the more and more the disposable flexible scopes are coming, which are not really disposable that way, but you can use it for a number of cases if you are very careful about the maintenance. But whatever happens, the size of the scope, the miniaturization of the size of the scope goes with the miniaturization of the access sheet. So the access sheet 9.5 French is replacing now the 12-14 French sheet. So standard is 10.3 by 12 is the standard sheet. The importance of it is that there is a very thin scope. There has to be some space between the access sheet and the scope so that the water flow is better, so that temperature remains cool, so that the intra-renal injury is not much. And so the sepsis is less, pain is less. But advantage of a larger sheet in a pre-stented ureter is that you can actually treat multiple stone by not necessarily pulverizing. You can take a small fragments time and again, which you cannot do it if it is a 9.5 French sheet. Now these are the fiber is always a constant 200 micro laser fibers. There are no other second choice. Although the TFL or thulium fiber laser promises 100 micron fiber in the pipeline and 150 is already in the market. And what you need is a nitinol basket, 0 tip, but it has been surpassed by the Engage forceps, which is much better in the picking up stone. The guide wires are either the by wire you can take to railroad it, or you can have small fiber, the basket, the guide wire of 3 French. This is the set of equipments you need the trolley. You can see that what is the rigid ureteroscope doing in the flexible ureteroscope setting. But that is very important. As you can see that the rigid ureteroscope actually takes the path as a path pilot and dilates the ureter at the same time. While you are putting a 7 by 8.5 French ureteroscope in a stented ureter, it may be easy. What happens? The 8.5 French becomes at the level of the VUJ. So you can jolly well put a 7.5 French access sheet. And at the same time, you can see the path of the ureter, that there are no damages, no other ureteric stone in the ureter, and the ureteric passage is good. As you can see that this is the access sheet and this is the introducer. So this access sheet has got an inner sheet. That inner sheet also acts as a dilator. So the dilating the passage is, if it is a non-stented ureter, is number 1 by ureteroscope, which could be 6 by 7.5, but we prefer 7 by 8.5 to make sure the access sheet of 7.5 goes easily. And then after that, you put a inner sheet first to calibrate it, and if it goes well, then you put the whole sheet together. That's the technique over a guide wire, zebra guide wire. And then you have got this basket, either a nitinol or a 0 tip basket or a Engage. So this is the way one should have that trolley laid. Am I audible? Can you hear me, Rajesh?
Sir, we can hear you, sir.
Hello?
We can hear
Am
you.
I audible? Can you hear me?
Yes, sir. We can hear you. Yes, sir.
Okay.
We can hear you.
Now, now this is the table layout. It should be done because if you stand here, everything should be in your vicinity. So you have got your access sheet, you have got a pump for which you infuse water inside, you have got the scope, and that is the trolley which is gone out of the site because that had the cystoscope, that had the rigid ureteroscope, that had the guide wire, and so once this is done, this is out of the space. Now this trolley comes into action. So you can see that the guide wire is already in the place, and on top of it guide wire, you can actually put the inner sheath first, and if that is calibrated well, you put the full sheath. So a lot of patients had a pre-stenting. There is no harm in pre-stenting a ureter, and there is nothing to be embarrassed about it. One needs to be safe. Now here are some tips and tricks I am giving. There are just a very few points to talk about. You have all seen all of them from the morning, and that explained everything. Now the first thing I want to mention, that secure your guide wire. This is very important, and the best way to secure your guide wire is to put the guide wire into the original casing of the guide wire when it comes. This is the original casing of the guide wire from which the guide wire came out. If you can coil it there, it acts as a very secure guide wire. So that is the first trick. Second is that calibrating the ureter. As I said, the first was the by putting a ureteroscope 8.5 calibrated first. Then on the top of the guide wire, you put the inner sheath. That puts a second calibration. Not necessarily you have to do that one. If you think is a already stented ureter, you can go for a straightaway dilatation. But important is the access sheath. What I want to mention, access sheath has to be in the same axis as the VUJ. So it is always helpful if you have got a C-arm focusing on the VUJ. So you know that there is no coiling inside the bladder, no coiling of the guide wire, and the access sheath goes straight in the line of the ureter, and it goes straight to the sheath. That is much more helpful. So if you have got a guide wire C-arm, please take the help of the C-arm to put the first 2 inches of the guide wire, of the access sheath. Once you crosses the VUJ, it is a matter of cakewalk. You go in. So if the still, after that 8.5 is tight, inner sheath doesn't go, no question of putting the outer sheath. You either stent the ureter, come out, you can do a balloon dilatation or Syrian Teflon dilatation, but it is safer to put a stent and come back, and you always counsel the patients beforehand that you may have a second procedure after 7 to 10 days. It becomes a different ball game after 10 days. Now while you are putting the guide wire, access sheath, just watch. The access sheath goes below the PUJ, and the trick is that no suction, no flushing, just wait. The water will flow and the vision will be clear by itself. You can see the vision is clearing up. Now if you start sucking, there will be hemorrhage, and that will blur the whole thing. So that is a very important trick to remember. Once you put a guide, the access sheath, and go inside the kidney, just wait and wait for some time, it will clear up. Now these are showing the movements of the scope. That is very important. Any scope has got an external rotation, internal rotation,
flexion, upward and downward, and forward and backward movement. Apart from that, there are all the movements are fruitless or not purposeful at all. As you can see, this is one will be deflection of 270 degree up and down. Now this is a futile movement. This is not going to take you anywhere. External movement on the right side, on the left kidney, will show you the lateral callus. Internal movement will show you the pelvis. Vice versa on the right side. And the deflection from this area will show you the 270 degree angle of inward or upward deflection. Mind you, 270 degree is without any laser or dormia. Once it basket, if it is a laser, 270 comes to 210 and the basket is about 230. But this inner and outer sheath is a excellent movement. But it is always, so you see, for the left kidney, once you are putting on the lateral wall, like calluses, your hand movements are very strenuous. So we have seen one today, Sishan, that equipment that has got a lock inside where you can keep your hand steady and put the lock to make a inward or outward movements. Now once you are inside, just see the Randall, identify the Randall's plaque and never forget and never make a mistake of doing a laser on the Randall plaque. It will bleed viciously. So once you're in, have a good look, just put the Randall's plaque. Oh, so the no other OTs are ready, so I'm just carrying on with some few slides and to show you some tricks. So my idea is to emphasize on the point, never venture on a Randall's plaque to do a basket, to engage or to do laser. You will be in deep trouble. Now this is how you handle the basket. So you have to have a steady, straight the scope, and the basket goes inside. What you are seeing is a zero tip basket, which was very popular so far, but nowadays the engaged basket is much more popular, and it can actually take stones from deep inside the diverticulum. And the trick is that once you're near the basket, your assistant will open and close the basket according to your instruction, and your job is to put the basket on the top of the stone, like a garlanding. Like a garlanding, you open the thing and go on the top of the stone and then close it, rather than closing it before. So see, you are actually moving in and your assistant is closing in. That is the thing, and that's even better with the engage. Engage, you can do it in a much safer way. And the basket, you must appreciate, if you are doing it at the lower pole, you are not enjoying the 270 degree upward or downwards movement. It is coming down to about 230 to 40. But the baskets are much more malleable than the laser. Laser deflects it to 210. And so you have to straighten it up, put the laser up, then take it down to the lower pole, and then protrude the laser fiber. So apart from the inability to put a laser fiber in a bent condition, you actually damage the scope. So you have to put it straight and then put the laser fiber, and then. Are we starting that one? এটাকে এওটি দেওয়া যাবে না? Okay. I think we are going to start the HOLEP, so we stop here. We can do it later on, maybe on the second part, a little bit of more trick and the other sort of low energy, low frequency, low energy, high frequency, pop dusting. Those are the, you have already all discussed today. Before we finish, let me just go on a, this is the high energy, low frequencies for the fragmentation. And low energy, high frequencies for dusting. Just imagine that one. In between that, the medium energy, medium frequency is for the pop dusting. The other important thing is about the relocating stone. If you think you're in the lower pole and you cannot actually fragment the whole stone, after making a reasonable size, you can put the basket and then relocate the stone in the upper calyx and jolly well do it like here you can see that one. And then basket is much easier. You can see that one. Again, the same principle of girdling the stone and go stop, grab it and put it on the upper call. So this is the one example I'm showing, a rather and caution, word of caution. Like Pushkar was very candid in showing a infundibulatory nicely done and got the all stone out. This is another one with the infundibular, do it for the diverticular stone. And one incision, you don't know what to give. There is always a chance of bleeding. So one has to be very careful and slowly going and then take the stone out. But if there is if it shouldn't be done in a lower pole, I tell you what, in the lower pole, if there is a bleeding, you will not get an access. Like this is the one where the infundibulatory was done and it started bleeding, as you can see that one. But I was lucky because it's in the upper calyx. I didn't venture in the middle calyx or lower calyx, and you can see the bleeding. Then what I did, I changed it to a rigid rotoscope with 550 fibers, defocused beam like a laser, and stopped the bleeding. If it was a middle calyx, I would have been in a bit deep trouble. The last thing is that visual exit. After you have done everything, you are happy with all those things, you must come out while looking at the ureter. That traxia 1, 2, 3, there are 3 levels of injury. Traxia 1 is a medial, the mucosal contusion, which must happen in everywhere, but 2, 2, 3, it shouldn't happen. But you must come out with the sheath, with the scope, and throughout the ureter, you have to see that one. So ultimate success is on the proper equipments, well-working C-arm, plenty of patience, and the results, as you know all about it, that there are other uses of RIRS which you can, maybe we'll see today in the last case, where there is an unexplained microscopic hematuria. So there is, sometimes you find out a small low-grade ureteric tumor, TCC, you can do a laser incision, and calyceal stone you can do an infundibulotomy. There are overall complications rate of 5 to 9%, 1% significant sepsis, stricture, and ureteric injury. The future of RIRS is a double lumen like we have always got. One, through the one channel goes the engaged sheath, the other will hold the stone, other will break the stone with the laser. 100 micron fiber is on the way, in especially the thulium TFL, thulium fiber laser, and obviously the future is the robotics, where we'll obviate the problems and minimize the radiation, although they are not yet in clinical use. There are indications for RIRS in pregnancy, coagulative disorders, spinal deformities, musculoskeletal deformity, and morbid obesity. Thank you very much. Torino.